Now we'll finish up with some other categories of lung-related issues, namely neoplasms, and then some environmental issues. Not going to spend a great deal of time here, but enough to kind of touch on some of the key points. So, neoplasms or lung cancer, granted, are a big concern for some areas of in the area of pulmonology. There are generally two distinctions: small cell and non-small cell carcinoma, and basically they're delineated based on the size of the cell, the way they appear when the tissue is on a slide and looked at under the microscope. So small cell you'll also hear referred to as oat cell carcinoma, which basically looks like an oat when you see it under the microscope. It is a highly malignant form of cancer, and it is often a metastatic cancer. Can typically have a large central mass somewhere that then metastasizes to multiple areas. Can metastasize to multiple areas in the lung fields. So not just in the structures, but just in the lung parenchyma or the visceral parietal linings of the lungs also, but can also spread to other organs or spread from other organs. So a small cell, very malignant, high mortality associated with small cell carcinoma. However, non-small cell is the most common. Notice about 85% of lung cancer cases are non-small cell carcinoma. That means that probably approximately 15% will be small cell cases. Adenocarcinomas are the most common among the non-small cell carcinomas, and that compromises about 38% of the lung cancers out there. The incidence is increasing among women. I don't have an answer for that. There are multiple things. There are multiple potential carcinogens in the environment. So these are things that you can't necessarily point to a specific cause other than smoking. Smoking gets the biggest black eye here. Of course, it rightfully earns it. You're inhaling many carcinogens when you smoke. Again, if you smoke, I don't feel bad about making you feel guilty for smoking, because you are increasing your risk for multiple issues related to your lungs. But that doesn't necessarily mean that there's an incidence in smoking increase among females. That's not what that's saying. There are a variety of things that can precipitate a mutation that can then produce a carcinoma. And it's typically, adenocarcinomas are typically in the peripheral portion of the lung, which means it's not in the central structures, such as like the trachea or the bronchi or something like that. Squamous cell carcinoma is about 20%. It has a whorl or nest-like appearance under the microscope, and it's usually in the proximal airways, airways more proximal, so larger structures, and can cause cavitation. So basically, squamous cell carcinomas can destroy portions of lung tissue and then just leave a vacant area there. Now, that subsequent vacancy or cavitation is the best way to understand it. So think of cavity, it's exactly what it means. That cavitation could then be susceptible to other complications such as pneumothorax or perforations in airways and things like that. So they have a whole other set of complications associated with squamous cell carcinoma. And then large cell carcinoma is approximately 5% of epithelial cancers, and it's also typically in the periphery of the lung and can cause necrosis of lung tissue, perhaps cavitation, but not necessarily. So the way they're going to distinguish this is you have a patient who presents with shortness of breath. They maybe perhaps have not had a history of this before. Maybe they have. We do some imaging, chest x-ray, CT scan, and we see an area of the lung that's suspicious for an ODG or out of odd shape or something that is shaped or dense outside the normal characteristics of that particular type of tissue, and we need to explore further. So we start with things like chest x-ray and CT scan, and then that tells us, well, we need to get a piece of that tissue, and depending on the location of the tissue can depend on the next test. So needle biopsy is the next test, but how we get there is determined by where that tissue is. So if it's accessible through a bronchoscopy, then we may do a bronchoscopy, go into the lung fields and take a biopsy of tissue from the inside. If it is not in a spot that's easily accessed by bronchoscopy, then that may be a interventional radiology, needle-guided biopsy through the chest wall. So that biopsy can be taken a couple of ways. That may result in needing to do a thoracentesis or thoracoscopy if that test is non-diagnostic, or we need to see the extent of tissues more specifically affected. Then we may need to open a portion of the chest, tap into the chest, and do a thoracentesis, perhaps take some fluid from the area. If in the case like a thoracentesis or a thoracoscopy, we may need to open the chest wall and excavate a portion of tissue. Ultimately, we may end up doing a thoracotomy where we actually remove a portion of the lung, if not a lobe. So that's how that can progress, thoracotomy being the most invasive there. Now, MRI and PET scans still fall into this to help identify areas that could be related to what we suspect is the primary source, and they will tell us about areas that respond consistent with the way cancerous areas may appear. Now, I want to back up and just do kind of a higher level reference to what is meant by neoplasm or cancer. There's a misconception that cancer is some kind of invasion or a weird tissue that shows up in the body. And actually, what cancer is a mutation of normal tissue that grows in an irregular way, whether it's with its morphology, the way it's shaped, or the rate at which it reproduces. Just about all cancers have a change in the way the cells reproduce, the frequency with which they reproduce. They reproduce faster than those cells would normally and produce abnormal growth. They may also alter the size so that they aren't shaped and function the way the lung tissue in that area would normally function and be shaped. And that can have deleterious effects, obviously, depending on its capacity to spread and propagate to other areas and other cells. So that can be problematic. That's what's meant by cancer. And MRIs and PET scans help identify areas that we refer to as hotspots that are showing characteristics of behaving in that way. So treatment for cancer is going to vary based on the manifestation of the cancer, the spread, the severity, concurrent conditions going on with the patient. So one treatment approach is radiation, and it has it can be effective, but it is rarely curative. Commonly, radiation will be used to help debulk the tissue, and what I mean by that is help reduce and decrease tumor or the cancerous area, reduce its size, which can facilitate surgery so that we're having to cut less, and may also facilitate that neoplasm or that cancer's response to chemotherapy. So it's quite common you're going to see radiation and chemotherapy used in conjunction to each other. It could be that we use radiation to reduce the size, and then chemotherapy can address the remaining cancerous tissue. It may be that radiation reduces it enough, then we can remove that tissue surgically, then we can administer chemotherapy to help address any residual cancerous cells that could be in the area that are just not visible to the human eye, or perhaps even visible to X-ray. So that would be one way, and you could see where PET scans could augment this, because it could identify areas where there's tissue that's acting like cancer. It may not visually from the naked eye look like cancer or show up on X-ray. Now, radiation will damage, of course, the cancerous tissue, but it will also damage any tissue that's in the path of the radioactive administration of those rays. So that's why you will see apparatuses developed for patients that focus the radiation beams so that they address or injure or damage as little tissue as possible. They can also create a condition called radiation pneumonitis, which is where the lung tissue becomes inflamed and irritated as a result of the radiation, and looks and acts very much like a pneumonia, or perhaps even an ARDS, depending on the breadth of the radiation, and can be a highly critical condition and require intubation. So radiation pneumonitis is a pretty powerful potential complication here. So as I've mentioned before, radiation can be used essentially, it can be a treatment, it can also be an adjunct or just a component of the whole therapeutic process. It can also be a comfort measure. So if there is a tumor, a neoplasm, that's creating pressure on a large airway, for example, it may be that the patient has metastasis to other lung tissue or other organs, and there's no hope that the radiation would be curative. The radiation may reduce the size of the tumor in an area on a nerve of the back or something, or perhaps even on an airway. It may reduce the size enough that the patient can breathe and have a fairly comfortable life for the last several months or weeks or a year or more, perhaps, at the end of their life. Surgery, while being an option and is used as a part of treatment, may not always be the answer or be possible because of the location of the tumor. There are occasions where the tumors can be inoperable if they're wrapped around large vascular structures or integrated into large vascular structures, or even pleural structures such as the trachea or bronchi. It may not be possible to do either radiation or surgery, because in doing so you would damage or perhaps even destroy the tissue that needs to be there for functioning. So there are occasions where that's not possible. There are occasions where things can be done. Surgery can be done anywhere from removing nodules to removing a section, which is called a wedge resection, where you go in and basically cut a wedge out of that portion of the lung, remove it, and then anastomose the remaining tissue. You could go in and remove a portion of a lung, a lobe. So that's larger than a wedge resection, but smaller than a pneumonectomy. A pneumonectomy would actually be removing an entire lung. So that's entirely possible. In some cases, I suppose, lung transplantation may be possible if there's no indication that there's going to be any kind of recurrence of that particular type of cancer. And then, of course, palliative care, depending on the staging of the cancer, its location, metastasis to other organs, other tissues and organs that are involved. And some of these agents and interventions we've discussed can be part of the palliative process in creating a comfortable state of existence for these patients. One of the things that becomes very important in these conversations, because we emphasize so much the importance of airway and breathing, that palliative measures and advanced directives become very important. So getting clarity among the family and the patient, between these groups of people, what is really desired and wanted for not just intubation, but also for other interventions such as CPR and IV drugs that support life. Those have to be a part of this conversation when it comes into the discussion about lung cancer. Patients who have advanced forms of lung cancer rarely are able, once intubated, to get extubated. So that's one of the challenges to intubating these people. And those conversations have to be held very clearly, very directly, and also very compassionately, as you might imagine. So just briefly, want to talk environmental and occupational atmospheric pollutants. This is an area, obviously, of growing concern in our culture because of just the number of automobiles we have out there. So if you look at these two wedges, you can see that the predominance of carbon monoxide as a contributor to lung pollutants. And this comes back to the cancer conversation, because any of these hydrocarbons, carbon monoxide, and nitrogen oxides, as well as sulfur oxides, are potentially carcinogenic. So we have a lot of stuff going into the air that can traditionally produce mutations in our lungs, aside from, smoking, yes, but a lot of other things as well, specifically driving. You can see transportation. The internal combustion engine contributes a large portion of the source for carbon monoxide, as well as, I don't want you to think transportation 49%, that's 50% carbon monoxide. Bear in mind, transportation and the byproducts of exhaust contribute all of these, many of these things in the types of pollutants. They're just 49% of the overall contributors of all those pollutants. And the biggest pollutant there being carbon monoxide, which, as you know, is also causing some issues with climate change. And then you have fuel combustion. So again, internal combustion engine there, which is another 28%. So that's 3/4 between the 49% and 28. That's 3/4 of the sources of some of these atmospheric pollutants that are just from internal combustion engines. And that is why we're looking at alternate energy and alternate fuel sources, as well as renewable energy. So it just makes sense from a health perspective as well. And then you have also a pretty sizable contribution from industrial processes. I don't expect you to memorize these percent numbers, but just kind of helps you quantify what's going on out there in the air that we breathe. And this picture right here shows you the evolution of how this progresses from inhalation, impaction, bringing it in where it impacts the back of the airway, and then it settles into the major airways, the bronchi, the mainstem bronchi, and then the bronchioles, and progresses into the alveolar areas and creates issues. So you can see how that just inhaling something can do that. And while we talk about this, there are also other inhalants. And I like to tell a story. I had some guys doing some landscape work at my house, and they're cutting stone. So these big, the very thick sandstone rock, they're cutting into certain shapes in order to be able to lay it. And they're using a cutting blade on a grinder, and there's just tons of rock dust flying into the air. And I just see these guys working and inhaling it. And they spoke very little English. They probably spoke more English than I did Spanish. So that's saying something. So they're inhaling all of this, and I took masks out to them and I'm trying to communicate to them the importance. They probably thought I was kind of crazy and super paranoid about COVID because it was in the era of COVID-19 outbreaks, but it was really unrelated to COVID. I was concerned about them inhaling all this rock dust. And you can think of a variety of atmospheric conditions, occupational conditions, where there's dust or pollens or other debris in the air that you're inhaling and impacting the lung tissue. Here is a list of common atmospheric pollutants and kind of their sources. So carbon monoxide from smoking, as well as fuel combustion. That carbon monoxide loves hemoglobin. It has a very high affinity for hemoglobin and that's why carbon monoxide poisoning can be lethal. When people do this, they try to commit suicide this way with their car and the exhaust. The carbon monoxide itself does not have an odor. The exhaust does, but that's because of the other byproducts of fuel combustion. But carbon monoxide itself does not have an odor, which makes it very dangerous. That's why they put an odorant in things like natural gas and propane, so that if they are leaking in the house, you can smell them. You're smelling that agent they've added, not the carbon monoxide that's part of those natural gases. Nitrogen oxides, such as the things that come from power stations and other fossil fuels that burn at really high temperatures. Sulfur oxides, refineries and power plants. Pneumoconiosis, which is inorganic dust, like coal miners experience. So that would be like coal miner's lung or black lung you may have heard of in the past. That's from this particular agent. And photochemical oxidants, such as car exhaust, other things that are in the car exhaust aside from the carbon monoxide. And silicosis, which is related to silica being airborne. And in areas of quarries and sandblasting, this stuff gets airborne, and it's just basically you're sandblasting your lungs, which can create some real issues. So solutions here for these things like asbestosis and bisonosis and these where you're encountering inhalants, masking is huge. And asbestosis may require more than just a simple mask, but a complete isolation suit if you're working in environments where there's asbestos. So creating barriers to the lungs is huge in help preventing some of these occupational and atmospheric pollutions, pollutant related illnesses. And then other occupational asthma, which really just comes down to what is the irritant. Things like toluene or organic dust, different cleaners, bleaches, things can exacerbate people's asthma. And then I've mentioned nursing here just for you to think about what are the things that are occupational hazards as a part of being a part of nursing. You can contract COVID-19 from a patient. You can contract TB from a patient. You can develop MRSA as a complication of being around patients. So multiple occupational related illnesses that can result. We could go on and on with that, but there's not really a need. So I just wanted to touch on those things for you. And there you go.